Chapter 25 Analgesics. Pain is an unpleasant sensory and emotional experience related to tissue injury, and nurses must be knowledgeable and skillful both in the assessment and measurement of pain, as well as to achieve that optimal pain management. It is the fifth vital sign. We always want to be cognizant of pain, we always want to be aware of our patient's pain. That everyone reacts to pain differently. What would be an excruciating pain to one person may be very manageable to another. So it's going to be a very subjective experience, individualized to each patient. The pain tolerance is the amount of pain a person can endure without having it interfere with their normal functioning. The pain threshold reflects the level of stimulus needed to create a painful sensation. Analgesics could take two forms, opioid and non opioid, and both would have different mechanisms to accomplish the same effect of lessening that pain. The most common classification of pain is by duration. Types such as acute, chronic, cancer, somatic, superficial, vascular, or visceral. In the gate theory, a tissue injury activates nociceptors and causes the release of chemical mediators, such as endorphins. These are hormones that naturally suppress pain conduction. Opioids work to activate the same receptors as endorphins to reduce pain. To ascertain the severity of pain, the best way, especially for normal, cognizant, functioning adults, is to have them rated on a scale of 1 to 10, 10 being the worst or most severe pain. A very new phenomenon, relatively new phenomenon, is going to be the undertreatment of pain. Unfortunately, in the early 2000s, with Oxycontin and the opioid epidemic, opioids were, in many cases, overprescribed, which has now caused a major regulation shift, which has caused the pendulum to swing completely in the opposite direction. And unfortunately, we're now seeing patients who are, in my opinion, underprescribed pain meds. There is dangers to both sides, but we never want to leave our patients in pain either. Up to 80% of patients have unrelieved pain in the United States. And the reasons for this are sociocultural variables, an inability to describe pain, fear of substance use disorder, an inability of the nurse to measure the pain, inaccurate analgesic doses, and other attitudes within the healthcare team. And this can have harmful effects that involve nearly all organs of the body, as chronic pain can have a very serious impact on many different body systems, both physically as well as psychologically. In the case of non opioid analgesics, these are less potent than opioid analgesics and can, in most cases, be purchased over the counter. They're used for mild to moderate pain and effective for everything from headaches, minor abrasions, inflammation, muscular aches, pain, and mild to moderate arthritis. NSAIDs are going to be a very common form that we're going to talk about a lot about this term. NSAIDs, things like aspirin, ibuprofen, naproxen. They have many different actions, everything from analgesics, antipyretics or reducing fever, anti-inflammatory effects, as well as the decreased platelet aggregation. The first one's going to be aspirin. This is the drug of choice for arthritic pain and inflammation. It has, again, those analgesic, antipyretic, and anti-inflammatory effects, and can have many side effects. Tinnitus is going to be a very common one. Make sure that you'll see in ATI and NCLEX a lot of reinforcing to the patient that this tinnitus from aspirin is only temporary. It can also have effects like vertigo, GI distress, excess bleeding, metabolic acidosis, hyperventilation, anaphylaxis, bronchospasm, dyspnea, and that Ray syndrome we talked about previously, which you're no doubt going to hear a lot more about in your pediatric course. Ray syndrome is a condition where, when the patient has an active virus, when combined with aspirin, that pediatric patient can get severe swelling of the brain and liver. Acetaminophen is not an NSAID, though is possibly far and away the most common over-the-counter analgesic. It works to inhibit prostaglandin synthesis, and it's used for things like muscular aches, pain, and fever. Keep in mind it has a maximum dose of 4 grams per day, and only 2 grams per day if taken frequently. This is because acetaminophen can be very hepatotoxic, toxic to the liver. And there are a lot of patients out there on the transplant list who are on there because they took too much Tylenol and destroyed their liver. People look at over the counter medications as these benign things, when really you want to be very careful, even with over the counters, as they can have serious adverse effects. Side effects of Tylenol include everything from anxiety, headache, insomnia, fatigue, constipation, peripheral edema, and low instances of GI distress. Again, it also has that toxic effects, especially to the liver, as well as can causing blood dyscrasias and hearing loss. Anytime we give any analgesic, we want to make sure that we're both assessing the pain before as well as after to ascertain how effective our treatment was. We also want to obtain a medical history, looking for liver dysfunctions, any other acute pains, injuries, discomforts, and looking at other non-pharmacological approaches that could be combined with our pharmacologic treatment. When giving acetaminophen, we want to check liver enzyme tests, teach the patient to keep acetaminophen out of the reach of children. Also, teach the patient to avoid any alcohol ingestion while taking acetaminophen. Encourage the patient to report any side effects, and check those serum acetaminophen levels if toxicity is suspected. For opioid analgesics, this is going to be used for moderate to severe pain, as well as antidiarrheal effects and antitussive effects in the case of cough syrups. The action site works directly on the central nervous system, working to suppress pain impulses, and unfortunately can also suppress respirations. That's going to be one of your priority assessments anytime you're giving opioids, is that you're carefully assessing that respiratory rate as well as their SpO2. Side effects will include things like nausea, vomiting, constipation, urinary retention, orthostatic hypotension, and respiratory depression. These side effects just start sounding like those drug commercials online after a while. One of your common opioids is going to be morphine. This is used for acute pain, dyspnea, and also to relieve anxiety preoperatively. Side effects would include things like drowsiness, dizziness, blurred vision, orthostatic hypotension, dyspnea, dependence, GI distress, flatulence, constipation, urinary retention, and respiratory depression. And as with all opioids, our antidote is going to be naloxone or Narcan. When recognizing cues, determine the drug history and check for any drug allergies, as well as assess for their type of pain, location, duration. And we want to carefully assess, again, these patients both before and after treatment to both ascertain their pain level as well as to see how effective our treatment was. We're also going to be following up with these patients very carefully, assessing their respiratory rate and how they're reacting to a drug anytime, especially we're giving a drug like morphine. As with all analgesics, especially morphine, we want to treat them, we want to intervene before pain has a chance to reach its maximum. We want to begin treat them when they begin having pain. So it's going to be much easier to manage if we head it off before it has a chance to build and grow. We're also going to carefully monitor vital signs, including respiratory changes, looking for pupil changes, as pinpoint pupils are going to be one of those hallmark signs of opioids, and always have an naloxone available as an antidote anytime we're giving opioids. Meperidine. This is primarily effective in GI procedures and preferred to over morphine during pregnancy. Use caution with large doses in older adults and patients with advanced cancers, as there is dangers for neurotoxicities, including nervousness, agitation, irritability, tremors, and seizures. It has side effects including dizziness, drowsiness, euphoria, confusion, constipation, and dependence. Hydromorphone. This has an analgesic effect, is approximately 6 times more potent than morphine. Side effects include dizziness, drowsiness, confusion, orthostatic hypotension, weakness, constipation, urinary retention, tolerance, dependence, and again, respiratory depression. Another common method, especially for very serious surgical procedures during recovery, is going to be a patient controlled analgesia or PCA pump. This is where we have a bag, a pre programmed pump, and the patient can push a button and receive a dose, up to so many doses during a set time period. It's going to be medications used like morphine, fentanyl, hydromorphone. It'll have a loading dose, predetermined safety mechanisms, a lockout mechanism, and a near constant analgesic level. You can also go in and look at the settings of this PCA to see how many times they've pushed the button, how much they've received. Transdermal patches are another very common method of pain relief. It's also one you as the nurse want to be very careful with. Make sure that you have, and anytime a patient has something like a fentanyl patch, make sure when you're coming on shift, you are putting eyes on that patch. You are seeing it there. You are also making sure when you're removing it, you're wasting it properly, making sure it is there once again. It can provide continuous pain control and it's helpful for chronic pain. The fentanyl is more potent than morphine and can be available in various strengths. When looking at opioid use in special populations, things like children, older adults, cognitively impaired individuals, oncology patients, and individuals with a substance abuse history. Adjuvant therapies, these are used along with non opioid and opioid interventions and to potentiate that opioid, to potentiate that relieving effects. These would be things like anticonvulsants, antidepressants, corticosteroids, antidysrhythmics, and local anesthetics. Opioid agonist antagonists. These are medications in which an opioid antagonist is added to an opioid agonist, may be used to decrease substance use disorder. This is not necessarily used for things like cancer pain, though it is safe for use during labor and safe as well during early pregnancy has not been established. Now, bufene. We're going to assess for the type of pain, duration, and location before giving this drug, as well as obtain a drug history from the patient and note any baseline vital signs for future comparison. We're also going to pay careful attention again to any decreased gas exchange, hypotension, accurate vital signs, and make sure we're paying special attention to that respiratory rate and SpO2. Again, we're going to carefully monitor vital signs, assessing bowel sounds, as well as the date of the last bowel movement to identify any constipation early. We're also going to keep a careful eye on urine output and warn the patient not to use alcohol or any other CNS depressants while taking nalbuphine. Opioid antagonists. These are drugs that work to block receptors and displace opioids. Used as the antidote for opioid overdoses, again, naloxone, Narcan. Could also be used to things like reverse the effects of respiratory depression, sedation, and hypotension. Side effects, adverse effects would include things like sweating, tachycardia, nausea, vomiting, bleeding, and a reversal of analgesia. Migraines and cluster headaches. These can last for hours or even days, usually affecting women in their 20s and 30s. Migraine characteristics are things like a unilateral throbbing pain, going along with nausea, vomiting, and photophobia. The triggers could be anything from cheese, chocolate, red wine, aspartame, fatigue, stress, monosodium glutamate, missed meals, odors, light, hormone changes, drugs, weather, or too much or too little sleep. It could also be due to neurovascular events within the cerebral cortex. On the other hand, cluster headaches, these tend to be severe, unilateral, and non throbbing pain, located around one eye, and occur in a series of cluster attacks, not associated with an aura, and do not cause the nausea and vomiting often associated with migraines. More common in males and can be treated with everything from beta blockers, anticonvulsants, and tricyclic antidepressants. In the case of effective analgesics, things like aspirin in combination with caffeine or acetaminophen. Also, NSAIDs like ibuprofen or naproxen. In severe cases, opioid analgesics like meperidine, ergot alkaloids, or selective serotonin receptor antagonists like sumatriptan or zolmitriptan. For our first practice question, the next day the patient's pain medication is changed from morphine to hydromorphone. Which statement regarding hydromorphone does the nurse identify as being true? That be A, hydromorphone must be administered intravenously. B, hypertension is a common side effect. C, physical dependence does not occur with hydromorphone therapy. Or D, hydromorphone is more potent than morphine. That answer is going to be D, hydromorphone is more potent than morphine. Question 2. The nurse assesses a patient receiving morphine via PCA pump. The patient has a respiratory rate of 6 breaths a minute, and the nurse anticipates the administration of which of the following drugs? A, naloxone, B, sumatriptan, C, nalbuphine, or D, hydromorphone. And that answer is going to be A, naloxone, Narcan. Question 3. The nurse identifies which of the following is a common side effect, adverse effect of morphine therapy. That be A, diarrhea, B, hypertension, C, urinary retention, or D, tachypnea? And that answer is going to be C, urinary retention. And for our final question, a patient receives morphine sulfate for severe pain. The nurse assesses the patient 20 minutes later. What is the best indication that the medication has been effective? That be A, the patient verbalizes pain relief, B, the patient has an increase in heart rate, C, the patient is resting, or D, the patient has an increase in blood pressure? And that answer is going to be A, the patient verbalizes pain relief. Anyway, that's all we got for this chapter. I'll see you in the next slides.